Recording in progress. Then ಕೇಳ್ತಾನೆ ಇಲ್ಲ.
Yeah, we'll start, sir. Good evening to one and all. I heartily welcome all the members of API, KCSI, and other members of various organizations who have joined virtually from all over the country to attend this program of World Stroke Day on 29th October. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus, RGHS, KBN University, Gulbarga, and Dr. Muruganathan, past Governor, ACP India Chapter, and past Dean and past President of API. I also welcome our own committee members, our patron API, Dr. Maya sir, Dr. Murali Mohan, Chairman API Karnataka, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, Central API Member, and Dr. B.K. Mahala, Chairman KCSI, and Dr. Puneet Verma, Secretary. I welcome our today's chief guest, Dr. Satish Chandra, Senior Neurologist and former Director NIMHANS and Vice Chancellor NIMHANS, a great academician. I also welcome our today's speaker, Dr. Vijay Sharma, Professor of Neurology from University of Neuroscience, Singapore, a great academician, researcher, and a scientist. I also welcome our today's moderator, our own faculty, Dr. Vikram Udev, a dynamic senior interventional neurologist from Narayana Health Sciences, Bangalore. I also welcome our panelist, Dr. Jairaj Pandian, Chief of Neuroscience, CMC Ludhiana, is the past President of Indian Stroke Association, and he is the present President-elect World Stroke Association. A great name in the country who was instrumental in developing many stroke units in the country. He will be joining shortly as he has got many continuous programs to attend. Let us not waste time by reading their CV profile. Let us hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to lead. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya Deepajyotirnamostute. Deepajyotirnamostute. Shubham kurutvam kalyanam आरोग्यं धनसम्पदः. दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते. शुभं कुरु.
We are virtually honoring all our faculty.
ಈಗ ನಾ ಮಾತಾಡ್ಬೇಕು.
We are playing a short video of World Stroke Day as a promotional video. Now I request Dr. P.S. Shankar to address the gathering. There is some technical issue. He is not able to connect. Now I request Dr. Murali Mohan, President, Chairman API Karnataka. Dr. Murali Mohan, sir.
Thank you, Dr. Biradar, for inviting me to be part of this very, very important meeting. Today is World Stroke Day. We are conducting this meeting to respect and honor the people who have worked hard to eliminate this great problem from our midst. Obviously, stroke is with us, but the focus of the theme today is to prevent stroke. And the theme for this year is Together We Are Greater Than Stroke. We all realize that stroke is such a devastating event in the life of a person. But over time, we've learned that it's possible to prevent it. It's possible to mitigate the effects of it. We all recognize the important role that time plays in recognizing and immediately handling this. It gives me great pleasure to welcome all of you on this platform, leading neurologists, and to partner with the CSI in this important occasion. I see my teacher here, Professor Satish Chandra, from whom I learned a lot of neurology, a wonderful clinician and a wonderful academician, and a very good person, which to my mind is the most important thing. My great teachers like Professor P.S. Shankar, whom I hope we'll hear from later, an extremely academic colleague, Dr. Sangram Biradar, and of course, somebody who works with me on a daily basis, Dr. Mahala and Dr. Vikram Huded, an excellent interventional neurologist. Welcome to the audience, and I hope we'll be able to learn a lot from this and help our patients mitigate the effects of stroke if they've already happened, and prevent strokes before they can happen. And that, recognizing that the risk factors for stroke begin in all systems, is something all of us as physicians, pulmonologists, cardiologists, and not just neurologists play a very important role in. Thank you all.
Thank you, sir. Thank you for your kind words. Now I request Dr. P.S. Shankar, sir, to address them.
And Dr. Satish Chandra, Dr. Vijay Sharma, Dr. Muruganathan, Dr. Huded, Dr. Pandian, Dr. Murali Mohan, and office bearers of the API, Dr. Mahala and office bearers of KCSI, Dr. Ravi Kirti, Dr. Sangram, and members of both organizations. We have assembled today to listen to the lecture on cerebral hemodynamics in real life and the disease states, followed by a panel discussion on the World Stroke Day. This is being held as part of the World Stroke Day, and I welcome all the distinguished speakers for this program. World Stroke Day is observed on October 29 to underscore the serious nature and high rates of stroke, raise awareness of the prevention and the treatment of the condition, and ensure better care and support for the survivors. It is estimated that nearly 25% of the persons around the world will have stroke in their lifetime. Around the world, 80 million have experienced stroke, and it is noteworthy that 90% of those strokes could be prevented by addressing a small number of risk factors that includes hypertension, atrial fibrillation, smoking, diet, exercise. COVID-19 is known to increase the risk of heart attacks and stroke, and the intense inflammation that occurs throughout the body in severe cases is likely to contribute to the increased risk. High blood pressure is the single largest cause of the stroke and is associated with half of all strokes. Atrial fibrillation is found very commonly, and these can be prevented, identified, and managed. Smoking increases the risk of stroke. Inactive lifestyles increase the risk of stroke. Hence, one has to be active to reduce the risk. Cholesterol can increase the risk of stroke. Diabetes is another risk factor. Depression and stress are also linked to the stroke, and hence mental well-being plays an important role in reducing the risk. Apart from preventive strategies, the signs of stroke have to be recognized and undertake medical management as soon as possible to save the life and to reduce disability. Nearly 10% of the patients make an excellent recovery when looked after in a specialized stroke unit. Thrombolysis increases the chance of good outcome. Blood clots are broken with clot busting drugs. Such a treatment has to be undertaken within 4 to 5 hours of the symptom onset in many patients with ischemic stroke. Clot retrieval treatment increases the chance of good outcome by more than 50%. It improves the survival rates and reduces the disability for many people with ischemic stroke caused by the large artery blockage. Rehabilitation plays a crucial role in the recovery process. It helps in improving the function and the survivor regains as much independence as possible over time. We must not forget that 1 in 4 survivors may develop another stroke. The prevention strategy includes drugs to control the blood pressure, drugs to reduce the cholesterol, antiplatelet agents, anticoagulants, stenting, or surgery in selected patients with severe carotid artery narrowing. Changes in lifestyle helps to reduce the risk of another stroke. It includes eating a well-balanced diet, physically being active, tobacco-free management of stress, and a limitation consumption of alcoholic beverages. Many survivors of stroke will live the rest of their lives with some form of disability or impairment. The theme for the day Together We Are Greater Than the Stroke. World Stroke Day is celebrated as per the guidelines of the World Stroke Organization, WHO. The campaign is to heighten awareness about the signs, symptoms, and crucial emergency procedures related to stroke. Every year, World Stroke Day brings attention to a critical health issue. Globally, stroke stands as the second leading cause of death and the third leading cause of the disability. It is estimated that in India, the average stroke incidence rate is 145 per 100,000 population. Brain stroke are more common in elderly. We have assembled to listen to the experts on this vital topic. I have great pleasure to be part in the inauguration of this program, and I wish the program all success. Thank you.
Thank you, sir, for sparing your valuable time. Your words of wisdom are taken. Now I request Dr. Mahala, Chairman KCSI, to address you.
Good evening to you all. Thank you, Dr. Brother. On this day, what is called World Stroke Day, and I feel there are the 3 components of this day celebration. The first is prevention. How do we recognize this and prevent this by modifying the modifiable risk factors? Second, how do we pick up the signs and symptoms at the patient level, not at the physician level? And how do we manage the patient before the golden hour? So these are the 3 components I feel celebrating the World Stroke Day. And at the patient level, I'll say using the mnemonic, something called B fast. B is losing the balance or the unsteadiness of the gait. E is the eye signs, either the vision loss or diplopia or blurring. Then fast is the facial changes. Then A is the arm changes. And S is the speech. And last one is the T for time. So once the patient recognizes this B fast, then quickly he can reach the hospital in the golden hours. So with this, let me welcome all the speakers and delegates and faculty to celebrate the World Stroke Day and learn from each other and utilize this platform or the forum for the benefit of the patients. So thank you very much. Once again, welcome to this session. Thank you.
Thank you, sir. Now I request our today's chief guest, Dr. Satish Chandra, sir, for your inaugural address. Kindly unmute, sir. Unmute.
Good evening to all of you and organizing committee of API, CSI, and my friends here and my teacher, P.S. Shankar, as well as Dr. Maya, for giving me this opportunity to inaugurate today's important program on the World Stroke Day. I think you heard all the things from Dr. P.S. Shankar. Only I wanted to add that stroke is now a preventable disease as well as reversible disease. These 2 words, one need to remember that the stroke can be prevented and can be reversed. But what it requires is the importance of the immediate doctor whom the patient approaches should refer to the stroke-ready hospital. Now we use the word stroke ready hospital, which is extremely important because as the patient enters the hospital, the moment the time starts and the time tickles away very fast, and the golden hour has to be optimally utilized so that the patient can be reversed, as every minute there will be loss of neurons. And our main idea is to prevent as much as possible these neurons so that the functions can be reversed. So what was known as a disabling disease or with a high mortality has now become a reversible disease. And that is thanks to the invention as well as the utilization of the various drugs which we can use during the golden hour and understanding the hemodynamics. And aptly today, Dr. Vijay Sharma, our friend and a guest from Singapore, is going to talk on cerebral hemodynamics and how it can be utilized. Understanding of this disease in understanding of the hemodynamics in the health as well as in the disease state plays a very important role in reversing these disease. And that is why I was very impressed that the API has chosen Dr. Vijay Sharma for today's program and to speak on such an important topic on cerebral hemodynamics. So we have now waiting to hear him, and we will thank him for accepting our invitation on and giving me an opportunity also in the API to inaugurate this program on this important World Stroke Day. Thank you, Dr. Biradar, for giving me this opportunity. Thank you.
Thank you, sir. Thanks a lot for sparing your valuable time. Now we move on to the scientific session. I request Dr. Vikram Ude to take over for further proceedings. As already all the faculty have been introduced, over to Dr. Vikram Ude.
Sir, I request Vijay Sharma, sir, to start the lecture.
Thank you, Vikram. Thank you, Professor Satish Chandra, for a nice introduction and inauguration of this. Let me just share my slides. After hearing all these things, I expected that everything from stroke has been covered, whether this is about the primary prevention, early detection, use of thrombolytics, interventional neurology. Everything has been discussed, and I found that today is a Sunday evening. Nobody wants to be, bored with the core scientific talk. Plus, I realize that most of the people in the audience should be physicians. So I tried to keep it a very fun-loving kind of talk and a very easy thing. I'll try to simplify as much as I can. And most of the things, what I'm going to explain are what I understood about cerebral hemodynamics in the last 20-25 years of my research as well as academic career. Now, this is what we were taught from third year, fourth year, and fifth year of our medical school, that we have a cerebral autoregulation. Autoregulation just means that brain does not care much what is happening outside. It can maintain the cerebral blood flow at a normal level over a wide range of blood pressure. And you can see it here that from a blood pressure of 80/50 and all the way to 220/110, there is absolutely no change in the cerebral blood flow. Now, this is the beauty of brain. This is called as cerebral autoregulation. How do we maintain it? This is the important part. What happens is any acute insult to the brain, whether this is a ischemic stroke, whether this is a hemorrhagic stroke, whether this is a road traffic accident, or any other acute insult, this autoregulation is lost. And this is the reason why we get all kinds of damage to the brain. We can test the autoregulation as well as the reserve in the brain by various methods. It can be PET, SPECT, depending on what do you have. It can be xenon CT, perfusion, contrast-enhanced CT, dynamic contrast-enhanced MRI. I use a lot of TCD. If you use a PET, it gives you oxygen extraction fraction. If you use a SPECT, usually it's paired with the challenge with acetazolamide, which increases carbon dioxide. And you can see in this patient what happened was, this is the baseline SPECT. You can see the metabolic perfusion, the two hemisphere looks almost similar. Little bit of difference is there on the left. But when you challenge this patient with carbon dioxide in the form of acetazolamide injection, you can see a lot of metabolic perfusion is lost because this hemisphere could not increase the blood flow which was a demand by the carbon dioxide. So this is autoregulation, that the left hemisphere was unable to maintain the autoregulation. TCD is simple. I like it because this is very fast. Now you can see it. This is a 30-second test. Somebody is holding breath for 30 seconds. And what you can do is just by simple breath holding, you can see how the blood flow is increasing over 30 seconds. It nearly becomes 1.5 times. So that is the beauty of our brain, how rapidly it can change the blood flow. What we need to understand that, everything which is moving is always, it feels a resistance. This is what Newton, told us, that there is a resistance to everything. And that's the reason why things stop. That's the inertia. In our blood flow, exactly same thing happens. There's the resistance everywhere. None of these arteries, veins, capillaries, venules, they want the blood to flow. They want to stop it. And the maximum stoppage comes from arterioles. So resistance in our blood flow is mostly coming, almost like 2/3 of it is coming from arterioles. And most of our blood flow in the brain is dependent on these arterioles. Arterioles are in direct control of the autonomic nervous system. They have the sphincters. The sphincters are controlled by parasympathetic nervous system. If you activate your parasympathetic nervous system, they vasodilate. They will increase the blood flow. If you stimulate sympathetic nervous system, it causes vasoconstriction, will reduce the blood flow. So this is mainly working on arterioles. We use carbon dioxide. So carbon dioxide is considered as a limiting factor. It is considered as the strongest challenge to the brain over a short period of time. Each 1 millimeter mercury carbon dioxide increase will increase the blood flow by about 6 to 10%. And vice versa. If you decrease carbon dioxide, this is what will happen. The blood flow will drop by almost 6 to 10%. Now, how do we know how much carbon dioxide we are increasing? So I showed you one TCD frame of 30 seconds, and you can see it that if you look at my carbon dioxide at present and tidal CO2, this is somewhere between 36 to 40. If I hold breath for 30 seconds, this will go to 45 to 50. So roughly 5 millimeter mercury is the minimum which I'm going to increase over 30 seconds. And this is a big challenge to the brain. I showed you each millimeter mercury carbon dioxide will increase my blood flow by nearly 6 to 10%. So if I'm increasing by 5 millimeters mercury, I may increase the blood flow somewhere between 30 to 50 to 60%. It totally depends on age of the person and the habitus, plus pre-existing lifestyle of the person. How we calculate it, we use this formula called breath holding index. We calculate the mean flow in the artery in the brain, like MCA, middle cerebral artery, at the end of 30 seconds, minus the mean flow blood flow at baseline, divided by baseline, multiplied by 100, divided by seconds of breath holding. And what we are looking at a magic number of 0.69. If you achieve a number of 0.69 or more, this shows that you have a very good vasodilatory reserve in the brain. You can increase the blood flow in the brain whenever there's a demand. If you cannot reach the number of 0.69, this is where the problem starts. So where can we use this formula? You can use it for anything, whatever you want, wherever the blood flow in the brain is concerned, whether this is in carotid stenosis, asymptomatic or symptomatic, whether you are talking about intracranial stenosis, whether you are monitoring the stenosis progression, that my number of BHI, the breath holding index, today was say 0.8, and you want to see what happens to my cerebral blood flow in 2 years' time, you can use the same formula, and then you can test me again and you can say, fine. So my stenosis which was there, has it progressed or has it regressed? We don't have a method, 50% become 55%. There's no method like this. We always put a range, 50%, 50 to 69%, or more than 70%. We don't have something like 55%. We don't have 65%. We have a range on it. Or you can select patients for various interventions, whether you are doing a carotid stenting, whether you are going to do an intracranial stenting, or whether you are going to subject a person for surgery of any kind. I'll just show you one simple example. So this is a patient, you can do, this is a CT angiogram. This patient is having a severe stenosis of the left middle cerebral artery and presenting with recurrent TIAs, recurrent episodes of right-sided weakness, recurrent episodes of language difficulties in the form of aphasia, Most of these episodes in this patient were occurring early in the morning or whenever this patient was going for exercising. These were the episodes when they were occurring. We just did a simple test and I showed you this one, the right side, which is the normal side. You can see it over 30 seconds. It shows a very beautiful increase in the blood flow. While if you look at the affected side, instead of increasing during that time, this is dropping. So this artery was surviving, was keeping the blood flow in the left hemisphere to a bare minimum by causing maximal vasodilatation. So when we subjected this patient for breath holding, this patient increased carbon dioxide. But because the arterioles were maximally dilated, they could not dilate more. Rather, they allowed this steal phenomena. The neighborhoods, they stole the blood. So neighborhoods were vasodilating, they wanted blood. They will steal the blood from this poor artery. So this is the term which we use called reverse Robin Hood syndrome. So Robin Hood was one person who was stealing from rich and giving it to poor. Here what's happening is a rich artery is stealing from poor. Our brain follows our society's norms. If you look at the society over last 10 years, 15 years, 20 years, you will see the rich people, they are becoming richer and poor people are becoming poorer. This is exactly what happens in the brain. The rich artery, whenever there was a challenge, it became richer, the blood flow increased. The poor artery, left MCA, was the poor artery. When there was a stress, this artery, instead of increasing the blood flow, it dropped the blood flow and caused the symptoms. Another example where you can use it, you look at this one. This is the carotid artery. This is the common carotid artery. This is the bifurcation to external carotid artery and internal carotid artery. You can see a severe stenosis of the proximal internal carotid artery in the neck. The problem is you want to know what will happen to this patient if this patient goes for CABG. The problem in CABG is the blood pressure will drop at some point. Carbon dioxide may go up and down. Now, when the blood pressure drops during surgery, whether enough blood will flow through this artery or not, if enough blood can flow through this artery, this person will tolerate CABG. But the problem is if this artery is not having a good breath holding index up in the brain, then anytime the blood pressure drops during CABG for a prolonged period of time, or there's a hypoxia, or there's a hypercapnia in this patient will wake up after anesthesia from CABG with a stroke on this side. So this is where this test comes into play. This test, the breath holding index, I told you the number 0.69. It differentiates the carotid artery stenosis into high risk versus a low risk category. Like you can see it here, if the breath holding index is 0.69 or more, the risk of stroke per year in this patient is just 4%. It's a very small risk. This is a normal risk, even in those people who don't have a carotid artery stenosis. So it doesn't matter that there was 70% or 80% stenosis. But you look at it, if the number is less than 0.69, then the risk is nearly 4 times. So we can differentiate a high risk patient from a low risk patient and decide that, fine, this person we will not allow to go for CABG without correcting the carotid artery stenosis. So let me show you some interesting examples now. So look at this patient. So this patient, the history is that she is a 20-year-old girl. She is a student. She is doing her graduation. She is topper of her class. And what started happening was that every time she will go to the examination hall, she will start doing this kind of. So this movement will happen to her every time she will go to the exam. The problem was, what is this? She is a topper of the class. She is not something like a weak student who tries to manipulate and tries to come out of the exam hall or want some sympathy. So this is what was happening. I'll show you what was this exactly. This was published. The title was Involuntary Handshaking, Transient Ischemic Attack, a Seizure, or is it psychogenic? So let us go to another. So look at this lady. So this lady becomes anxious. This is what we called as hyperventilation syndrome. So look at it, what is happening to her. She's just hyperventilating. Her chest is clear. There are no crepitations. Her heart is okay. She is not in heart failure. She does not have a chest infection. She does not have a COVID-19 or anything like that. No chest infection, no fever, chest clear, heart, no murmurs, and no heart failure. She has a very good heart. So this is the therapist who comes And what she does, she did not bring any injection or any tablets to her. She just gives this paper bag to her. She breathes in and out of this paper bag. And look at it, what happens when she's breathing in and out of this paper bag. It does not take a long time. It just takes probably about 15 to 30 seconds. And she is going to be totally normal. And you can see it, her all dyspnea, whatever we were saying, dyspnea or tachypnea is gone. She is totally relaxed. And now she can remove it and you can see it, how relaxed she is. See, now she has become normal, right? Now let us see this person. So this is showing you what are the problems with laughter. All of us, we enjoy laughter, we laugh. Some people laugh in a different way. The different way is their laughter looks more like a hyperventilation. Now look at this person, just keep looking at his facial expression.
Oh, you've been doing this? Oh, we gotta take a picture on Instagram.
If you look at it, he was almost passing out when the friend just was doing like this to wake him up. So he was just uncontrolled laughter, which is causing all the problem. What was all this? If you want to explain all these things, the handshaking, the lady with hyperventilation syndrome, and this person, why he is becoming like this, the answer lies all in what happens to the blood flow when they do all these things. So what I'm going to show is I'm going to show you a blood flow in the middle cerebral artery of this person, the first one, the first girl which I showed you, which we reproduce in our lab. So I want you to see only this number, this 97.8, the mean flow velocity. And I asked this lady just to hyperventilate, what we do during EEG. And just, I asked her to do 5 times. This kind of movement 5 times only, and you keep looking at it, what happens to the blood flow. This is a second breath. This is the third deep breath. This is the fourth deep breath. And this is her 5th deep breath. I stop it here. And I show you, we started from somewhere around 197.8, and this had reached 37. So she has dropped the blood flow from 100 to 30s. This is the reason why she was having all the symptoms. So that first girl who was going to the exam, she was becoming anxious in the exam hall. And when we become anxious, all of you, most of you are senior, you have seen people, going for exams, sitting in the exams halls. We have all done invigilation. There are 2 kinds of students. One kind of student is one who looks at the question paper, takes the pen, opens the notebook and starts writing. He just thinks 1 minute, I'm going to answer question number 3 first and followed by question number 2 and then question number 5. And he starts writing immediately. The other person who is not prepared well, he becomes very anxious, and what he does. Now, the moment he does this one sighing breathing, he is taking a lot of air in, he's dropping his carbon dioxide, and this drop in carbon dioxide reduces the blood flow. So whatever this student remembered or he read, he forgets that also. So we need to teach our students that the moment they feel the question paper is difficult, don't do all this thing. Better to do it, put your hand, make a cup, and breathe in and out of this one. Instead of washing out carbon dioxide, instead of reducing carbon dioxide, just rebreathe into this hand, or take a paper bag to the exam hall and just put the paper bag on your nose and mouth, breathe in and out it. It will increase the blood flow and you may remember what you read in past. So this trace of TCD, it explains what was happening to these 3 patients. Now, this is what I feel that this is something, we were taught all these things we have been seen for centuries. There were a lot of things in our traditions, and then we have modern methods of medicine. Is there a link between them? And then I showed you the bad effects of hyperventilation. Do we use it to our benefit? That is another question. So I show you this one. All of you must have seen the weightlifting in the Olympics or Asian Games or any games weightlifting. what do weightlifters do? Now, if you look at it, what he is going to do, he is a gold medal winner. Or look at it, comes to lift the weight. See, he does a few deep breaths, and then he holds the bar, and you again look at his mouth before he lifts it. Look at, he is washing out carbon dioxide. See, he is doing hyperventilation. This hyperventilation, he lifts it up, and then he throws it down. So if you look at it, what he did, so he is probably, I can feel that he must be around 70 kg maximum. And this man is lifting almost 150 kg weight. A 70 kg man lifting 150 kg weight, I say this is not a human activity. This is an inhuman activity. Now from human, he has to become an inhuman. How do we become inhuman? You knock out the brain. If you knock out the brain, you can do anything which is inhuman. So by hyperventilation, training part is a separate thing. He has been training for years. That training is a very important thing. It's not only the blood flow in the brain. Training is very important. But he has to remove all the fear. What he did was, he did hyperventilation. He reduced the blood flow in the brain so that he cannot think what will happen if he dislocates his shoulder, dislocates his elbow, and suddenly he lifts it up. Now, every time we lift weight of any kind, anything more than 5-10 kilo weight, if you lift it up, it's a natural human body's response. We have to hold breath. The moment the weight was there with him on his head, he has to stop breathing. He stopped breathing, carbon dioxide increased, and suddenly he realized that he is holding 150 kg weight. You saw he did not put the weight slowly down. He threw them. He knew it. If it falls on his head, it's going to break his neck. So he was afraid that it should not happen. He throws the whole thing away rather than putting it gently down. So this was all about altering cerebral hemodynamics. So he used hyperventilation as a procedure to facilitate lifting that weight. Now look at this one. This one you people see every day. Early in the morning, if you go to a park, I'll just show you what the park does. So these people have unfortunately, most of these people are old people who go to the parks. The younger people don't want to go there. They have all assembled there. And look at it, what they are doing. So this was Laughter Club. People go there early in the morning, do this, ha, 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 ha. Now, if all these things were useless, then they will disappear. These things have existed for hundreds of years. You know, those people who understand Hindi, we were taught, our grandparents, they used to say, kabhi hans bhi diya karo. So, laughter is always a healthy thing for the brain. So by doing all this activity, what these people are doing is they are training their brain to survive for a longer period if the carbon dioxide goes down, if the blood pressure goes down, if the artery starts blocking like in stroke. So they can sustain the damage to a larger extent as compared to those people who have never done any exercise. So this exercise of laughter was training their brain to sustain ischemia better than anyone else. And that's the reason why these people, they come, because they know there's the benefit and they know what is the benefit. These people usually do not suffer from syncopal episodes, pre-syncopal episode, because they have trained their brain. They have trained their brain to survive and work even when the blood flow is less. So this is what the exercise works. Now, this is something very important, which I understood very, very late. So any one of you, if you have seen the wrestling. So wrestling is like this. The two Pehlavans, they come, they wrestle for say 1 minute or 2 minutes, and then there's a break. When there's a break, there are assistants. Now you look at this, these assistants, both, this is one wrestler, this is another wrestler. What are they doing? See, both of them are massaging legs. Even I forward it, everything is, so you saw everything was on the legs. Now these are wrestlers, they were not running. They were fighting, and most of the fighting actually hands are involved and everything is involved. But we know it very clearly that the fight basically is done from the brain. Anyone who can use the brain better, use better methods of fighting, this wrestling, and win the battle. But these people, they are massaging legs. Why legs? Legs were not tired. Legs were not being used. They were not kicking each other. Of course, they were standing on the legs. That's the only thing legs were doing. So I'll show you what these people were doing. So these people were doing this kind of thing. All those who were trained through cardiology, we always heard about it.
The intra-aortic balloon
This
pump
intra-aortic
is a
balloon
mechanical
pump.
device that consists of a cylindrical balloon that sinks into the aorta and counterpulsates.
We put a balloon in the
It
aorta,
actively
which
in
inflates.
diastole,
So,
increasing blood flow.
so this balloon is synchronized with the ECG. As soon as the QRS complex is over, that means systole is over, this balloon will inflate. So it will not allow the blood in diastole to move downwards in the aorta. Rather, the blood will move backwards. When the blood moves backward, it will fill your coronaries better. So this was designed to help the coronary arteries to get more blood, used for unstable angina, angina patients waiting for CABG tomorrow. This is where we put this intra-aortic balloon pump for temporarily increasing the blood flow in the coronary circulation. So the previous one which you were seeing, so those wrestlers, they were working something, except that they were not synchronized with the ECG, but they were all working on the legs. They do not know that they have to push the blood up, that means leg and thigh both, but they were working on this. They were increasing the blood flow, not only to the heart, but also to the brain, because these are the arteries going into the brain. This is the right common carotid artery. This is the left common carotid artery. They were pushing the blood to the brain so that the brain becomes energetic, brain becomes fresh, so that this wrestler can think better about the opponent and can win it. So basically, this is the reason why he was massaging the legs. It was not to give comfort to the legs.
The intra-aortic.
Now, this is exactly what happens to the brain blood flow. This is in the carotid artery. You can see this is person's own heartbeat, and this is the heartbeat from the balloon. And when the balloon deflates, this is the deflation process. And then again, the next cycle starts. Now, this is the normal blood flow in our brain. Now, during this intra-aortic balloon pumping, this is what happens. Instead of one peak, we have two peaks. One peak from our own heart, one peak from the balloon. And this is exactly how it improves the blood flow. See, in between, I stopped the intra-aortic balloon pump, and you can see the normal blood flow in the background. And then again, you start seeing double peaks again. So this is how we can increase the blood flow in the brain. Now, what can we do? Something else for the brain. So that is something which is good for brain, good for heart. We are increasing the blood flow, but we do not want to puncture the femoral artery to put the balloon in the aorta, because you can keep this balloon maybe 1 day, maybe 2 days maximum. You cannot keep the balloon longer. It's an invasive procedure. It can have infection. It can have thrombus formation, and it has got its own complications. We don't want it. So can we do it something externally? So this is what is the external device. It's called as enhanced external counter pulsations. So what
During
this is having
EECP treatment,
having
3
this
sets of
one,
inflatable
something like a
cuffs
blood pressure
are
cuff
placed
on
around the
leg,
calf,
each leg, one
lower
on the lower
thigh,
thigh, and
and
one
upper
on the
thighs.
upper thigh. So there are 3 blood pressure
Coronary
cuffs.
artery blood flow is
They are
monitored via a
synchronized with the
plethysmograph
ECG,
probe, which is placed on the
and
patient's
they
finger.
are inflating one at a time.
3 ECG
So this is the
leads
ECG
are
which they are
applied
putting
to
up.
the chest.
So,
The
and
pressure
this
of
is
the
what
inflated
happens.
cuff
This is
returns both
synchronized.
venous and arterial
After
blood to the
every QRS complex is over, the cuff in the 2 legs will inflate. Then the cuff in the lower thigh will inflate. Then the cuff in the upper thigh will inflate. Everything is happening about 15 milliseconds after each other. So as if during diastole, you are squeezing the blood from leg all the way up to the upper thigh, so that we increase the blood flow backwards. So it will increase the blood flow to your kidneys during diastole. It will increase the blood flow to your heart. It will increase the blood flow to the brain also. And what exactly happens? So this is how it is done. This is my patient who is doing this therapy. You can see it. This patient is not sleeping. He is awake. He is talking. He can use his phone. He can watch videos. And this is the only movement. What is happening? He is jumping up and down because of these extreme pressures which we are applying. These pressures range from about 100 and we can go all the way to 300 millimeters mercury. It's very comfortable. It's not an uncomfortable thing. It's a very comfortable procedure which is done. During this procedure, what happens? How the blood flow improves. So this, I'm showing you blood flow in the finger. So this is your ECG. This is the QRS complex. And this is what you see the blood flow in normal. Nothing is being done at present. And then we start inflating these pumps at 160 millimeters mercury. These machines are available in India. At least I know there are at least 10 or 12 centers in Chennai who are having this machine. Usually cardiologists keep it for rehabilitation for the cardiac patients, but it's used for other purposes also. So you look at it, this is the cycle here, and we are using a pressure of 160. This is the noise in the machine, and you can look at the heart rate is 66 here. Just see what happens is during diastole, we start pumping, and you can see the tenting is starting in the diastole, and the double peaks start. So one peak is coming from the heart, and one peak we are giving it because we are pumping the blood back during diastole towards the heart, brain, and everywhere. And this is how the blood flow improves. So we can improve the blood flow in the brain externally, non-invasively. And this is exactly what happens in the brain. You can see it. This is the patient at baseline, the blood flow in the brain. And this is the blood flow in the brain once you start augmentation. This is exactly what I was showing you. This is at baseline. And this is the double peaks which start appearing. So we can improve the blood flow in the brain externally. And we can show it that, like in this patient, if you look at it, this patient was having bilateral stenosis. This is the old stroke on the left side. There's a reduced perfusion on the right hemisphere because there's a stenosis on the other side also. We put this patient on this counter pulsation therapy. We use the cardiac protocol. The cardiac protocol is 1 hour every day, Monday to Friday, for 7 weeks, total of 35 sessions. After completing 35 sessions, we gave this patient 2 months period of wash off so that any acute benefits are washed off, and we are looking for the chronic benefits. Understanding is when we are pumping so much of blood into the brain, we are nearly doubling the blood flow to the brain. Brain has to keep the blood somewhere, and that somewhere is brain opens dormant collaterals. Brain creates new arteries, neovascularization. And then it is like exercise. If I'm doing this kind of movement for 1 hour every day for 35 sessions over 7 weeks, my biceps will become strong. So all these new arteries which we are forcing the brain to develop, they become strong muscular arteries. They know how to do the auto-regulation, and they will keep it. You can look at the difference. This whole disappearance of the metabolic perfusion after challenge, it disappears. It's a complete reversal of the reverse Robin Hood syndrome. So we can improve the blood flow. This is something like at least a temporary method. Long-term methods will be interventional. We can put a stent there. We can do a bypass, or we can do something else. So I showed you some breathing patterns. I showed you, how hyperventilation helps. I showed you how the breath holding. The question is, can we take the brain, just train the brain? So one of them I showed you training the brain was a laughter club. So you can definitely use the laughter club, join it, you will have the benefits because you are training the brain. This is like a remote ischemic preconditioning. So you are training the brain, you are training your heart to survive at reduced blood flows. Now, another method of training, now this is a very common thing, but unfortunately West has taken it from India, and they just manufactured it their way. So I just show you what this man is teaching. So this man is basically teaching the students this kind of thing. He's teaching them.
Train Whittle to be calmer. Oh, I like the sound of that.
Just be calm.
This is called 4-7-8 breathing.
He's just teaching them.
So you want to start out by sitting straight up like this. Now, a lot of times when we breathe in from our chests, up here. But today we're going to breathe from a lot lower, from our diaphragm. What? Your diaphragm is right here, by your stomach. Think of it as a balloon underneath your rib cage. Oh, okay. Breath, like you're filling up that balloon and you're still through our mouths for 8 seconds.
So see, he is asking them to see and hold breath for 7 seconds. And then breathe out for 8 seconds. So he was teaching them, take deep breath, hold it, and then slowly exhale it. This is what we have been teaching in yoga. We have been teaching breath holding is good for the brain. It improves the blood flow. And we tested it. So this is the S. Vyasa University in Bangalore, in your own city. And a girl, this Nivedita, she was doing PhD and she was interested in blood flow. And when we talked, she said, I want to see what happens to the blood flow during different pranayama techniques, just a yoga techniques. And we found out, yes, there is a huge response of the brain to do the pranayama in a correct way. Then we tested that the two methods, one of them is this Kalpabhati and one is called Kumbhaka. These are exactly 4-7-8 kind of thing, except Kumbhaka is something like this kind of thing, which just decreases the carbon dioxide, but at a very slow speed for a longer period of time. So we have been teaching the world about yoga, but we forgot about it. It is just probably we have to mix the two, the modern medicine with the older techniques used in ancient world and find out what are the best methods. So these are the one methods which increase the blood flow, which helps you in auto-regulating. I'm not showing you increasing the blood flow only. Sometimes we need to decrease also the blood flow. I showed you where do you decrease it. So you are training your brain to live on a wider range of blood pressures, wider range of carbon dioxide manipulations, so that they will tolerate it. And we were using it even during COVID-19. We did not leave it. We found a lot of healthcare workers, who were in the front line, standing in the emergency rooms, wearing those N95 masks, they start having headaches. Nearly 83%, they complained of some kind of headache, either the worsening of the pre-existing headaches or the headaches de novo. We are finding out what is this. Is it just the pressure of the mask on superficial nerves, or it is something else? And we found that this is the carbon dioxide actually. So they were increasing carbon dioxide when they were wearing N95 masks, and they were causing vasodilation, especially in the middle meningeal arteries. So this is my own trace. So this is my baseline. You can see it, my resistance in the blood flow is 0.96. When I started using the N95, within 5 minutes, this dropped to 0.68. This caused vasodilation. And this vasodilation, if it is sustained for longer period of time, it even vasodilates my middle meningeal vessels, which have the pain fibers, and I start getting headache. So we found it that if you're using the mask for 4 hours or more, this is definitely going to give you headache, will reduce your efficiency, and will give you tiredness. So if you people work during COVID, you can realize it that after finishing your shift, how tired we felt. We were doing the same thing what we have been doing now. But during that time, just N95 mask was making us too tired just because of this excessive vasodilation. And we found out a solution that if we really want to use the N95 mask, instead of using the N95 mask, use this air purified respirator, which is something like this, that there is a mask, which is N95 filter. This is the tank, which is just a motor, which is pumping air, and the air is passing through another N95 filter. So this air is passing through all the way through this mask. So we are not allowing the carbon dioxide to stay here, retain here, and cause vasodilation. And not only one N95 mask, you are using 2 N95 masks. So double protection plus benefit. You can work later. And this is again my own, which I showed you. See, this is my blood flow in my middle cerebral artery at rest. This is after using the N95 mask. Within 5 minutes, this is exactly what happened. And when I started using this PAPR, this is exactly, I reversed it. I went back to my normal as if I'm doing a normal work, and everything was related to this carbon dioxide, which you are seeing here from baseline. The carbon dioxide about 36 went up to 40. It's nearly 4 times challenge. Actually, 4 millimeters mercury means my brain is being challenged 40%. And then the moment I use PPAPR, it comes back to normal, and I can maintain my efficiency without suffering from headache or without suffering from tiredness. So I bring you back to the same slide. This is perhaps the last slide, that This is our normal autoregulation, that between a blood pressure of 80/50 to 220/110, the blood flow in the brain remains constant. Now, if you are doing a lot of yoga exercise in a correct method, we can shift this upwards. So we can survive for longer periods. That means we can sustain the damage to the brain even at lower blood pressures here and higher blood pressures here. We can extend this straight line. Acute insult, there's no control. We have to go like this for a short period of time. It may be 1 hour, it may be 1 day, it may be 1 week. Usually in acute strokes, it takes about 3 to 5 days for the autoregulation to come back. Can we become like this? Now, this is impossible because there is a limit to the things. This is impossible, but certainly I showed you that this line, we can extend it a little bit and little bit on the upper side so that we can survive in a better way just by doing a minimal maneuvers. We don't need to go for exact yoga training. I'm not a yoga trainer. I don't want you to do yoga, but what I'm showing you, the effects of various exercise. And if you look back at the normal life, we don't need to go to exact yoga. If you are doing any kind of exercise which involves the breathing, and every exercise will involve breathing, is definitely going to change your this autoregulation or hemodynamic pattern to sustain the brain damage in a better way. So what I showed you was that autoregulation definitely is important in various physiological and pathological states. Our brain keeps working. We don't think much about it, how it's able to manage and why all these changes happen. And once you understand it, that it helps not only in understanding the things, but also treating a stroke patient better. This is exactly what's happening in a stroke patient. We can help our stroke patient. This is the kind of prevention which we can use. And even after the stroke has occurred, by all these things, we can improve the blood flow and probably contribute towards the stroke recovery. There's definitely a potential area of research for developing something with a better integration between the modern and the traditional systems of medicine. And this is what we have been taught from our school days. A healthy mind is necessary to maintain a healthy body. I showed you some of the methods to make a healthy mind, and this is probably will work better. This is how Singapore looks at this time of the night. It's a beautiful small place. Anybody who has not seen it, you're most welcome. I will be happy to host you. Just drop me an email and enjoy it. I'm happy to take any questions if any. Thank you very much.
Thank you, sir, for the excellent lecture. I thoroughly enjoyed it. If any questions are there, please.
Dr. Vikram, Dr. Jairaj Pandian has joined. You can have a comments from him. Then we can take the.
Good evening, Jairaj sir. Your comments, please.
Yeah, good evening. I know I just joined in between the lecture. There was another program with IA and IFNR. I know Dr. Vijay is so passionate about this topic, and I've listened to his talks in the past on a similar ground. And these are some of the innovative things that we need to look at the brain vessels. Now we can improve the collaterals, or we can improve the autoregulation. There are several efforts like ischemic brain conditioning. That is one of the things which people have tried, and we need more research, and it's all I would say exciting field. And Dr. Vijay's documentation using the TCD, it is live and dynamic, and the changes that are happening. And I think for preventing the damage to the brain after a ischemic stroke, there are plenty of options now, and technologies are evolving in order to improve the autoregulation, improve the collaterals, and so this is an exciting area.
Thank you, sir.
Yeah, Dr. Muruganathan, he was our guest of honor. He joined late. Dr. Muruganathan, sir, your comments before we take up the questions. Dr. Muruganathan, sir. Okay, carry on, sir. Vikram, we will take up the questions. If anything.
Yeah, yeah. So there is one question by-
Vikram, I have a question to Dr. Sharma. Is there any difference in the mechanism of autoregulation in patients with ischemic stroke versus hemorrhagic stroke? One. And number two is, by augmenting the diastolic blood pressure in the central aorta, how does it increases the perfusion in the brain? Not doing systole. When we put I am a cardiologist actually, when you put the intra-aortic balloon pump, the mean pressure does not change much and there is a drop in the systolic, that there is a diastolic augmentation. In this diastolic augmentation, how does it increase the cerebral perfusion by just putting a balloon pump or doing an exercise? The first part of the question I said, is there any difference in autoregulation between ischemic stroke versus hemorrhagic stroke?
So there is absolutely no difference between the cerebral autoregulation when it comes to ischemic stroke versus hemorrhagic stroke. There's absolutely no difference. It's an insult. We lose this autoregulation. What the difference is that most of the patients who come with acute hemorrhagic stroke, they come with a very high blood pressure. And if you look at the straight line which happens after acute insult, that line says that higher the blood pressure, higher the perfusion. So that makes the bleeding worse. So that is a problem with that side. In ischemic stroke, that may be to some benefit that this is an attempt to increase the blood flow by keeping the blood pressure on the higher side. That's the only difference. Otherwise, autoregulation part is similarly affected. Regarding the ECP part, the counter pulsations, the balloon, the intra-aortic balloon pump, I totally agree with you. If I do it on me or you, I can augment the blood flow in the brain for a short period of time. Then my autoregulation will come back, and this is exactly what will happen, that I will drop my systolic flow and I will increase the diastolic flow. But if you look at those blood vessels which are severely narrowed, severely stenosed, and they have lost the autoregulation, they don't have the vasodilatory capacity. In them, we can definitely increase the blood flow. We can increase the blood flow. We can nearly double the blood flow during that time. But healthy arteries, no. Healthy person, if he is doing, it becomes like a passive exercise only. It's not more than that. Because the brain auto-regulates very nicely, very fast, and it does not allow the blood flow in the brain to increase at all. So that is an excellent observation. And this is exactly, even in the coronary literature, what I know is, if you subject a healthy person with healthy coronary arteries and you do external pulsations or you do IABP, it's of no role actually. It does not have any advantages. But it works in severely narrowed coronary arteries just to augment the blood flow during diastole. So we are increasing the diastolic component only at the expense of decreasing systole a little bit less, because diastole is for a longer period of time. So we are helping the heart muscles or the brain parenchyma to sustain the damage, probably just fight it with it in a better way, because diastole is a longer component as compared to systole.
Yeah.
Vijay Kumar Sharma, I am
mentioned
Dr. Muruganathan.
the
Dr. Muruganathan,
resistance.
can I ask you a question?
Yeah, Dr. Muruganathan, sir, please go ahead.
Yeah, Vijay Kumar, very nice. After a long time, I'm seeing you in the Zoom. Very well presented. Good presentation, Vijay. My question is, in a cardiac patient, lifting something, even small weight over the head, the cardiologist say you should not do because it will have problem. Is it correct? Number two, where all we can use hyperventilation? Suppose somebody is very anxious. Can this hyperventilation help them to reduce their anxiety?
The problem with hyperventilation syndrome is that the person becomes anxious. Now, to overcome that anxiety, this person has to understand what is the reason for anxiety. And he has to understand that, he can manage the things and there's no need to be anxious. So he has to break that cycle. The problem is, in hyperventilation syndrome, the carbon dioxide starts dropping because of hyperventilation. Blood flow to the brain reduces. The person loses the power to understand the situation. And this vicious cycle continues. So somehow, at some point, you need to break this cycle. And that cycle can be broken very, very easily just by increasing carbon dioxide by some method. And I train my patients that no need to carry a paper bag in their pocket. And whenever they become anxious, they put this paper bag. The best solution could be just use your hands over nose and mouth as if there's a bad smell, and just rebreathe into it, you will increase the carbon dioxide and everything will go away. So this is how the hyperventilation, it just reduces blood flow to that extent that you start going on to a reflex activity, which is not using the brain. Once you can start using the brain, then you will know there was no need to be anxious. And then you feel that you can analyze the situation. You need blood flow to the brain to analyze the situation and to handle it properly. The carbon dioxide down.
What about the mask? Whatever normally we wear mask, wearing the mask. In the mask, can we do the same thing what you said?
You can do, but the problem in the mask is that there is a limited filtration. The good thing is these masks, they go through a quality control. That quality control, there's a NIOSH, NIOSH. That is a limit which you need to do. The masks, when they are used, they are fitted on human beings. That even with N95 mask, you do not cross that threshold. So that's the reason why these masks have been approved for human use. But they set you almost at 3 to 5% increase in carbon dioxide. Initially, you may feel better because carbon dioxide increases, blood flow increases. But when this is sustained, then what happens is you start opening up unnecessary blood vessels in your brain, which starts vasodilating. And the problem comes when this vasodilatation reaches the middle meningeal vessels. Because all our arteries inside the brain, they do not have pain fibers. So we don't feel pain at all with vasodilatation. But the moment middle meningeal arteries, they start vasodilating, they have the pain fibers, we start feeling the pain. And unnecessarily, we are keeping the blood flow higher. That is the problem. That's why we start feeling tired very early. We start consuming more energy and for no reasons. So that's the reason why. But even when you are using the N95 mask and you start breathing fast, that carbon dioxide is not going away anywhere. That's the problem. It is in the mask itself. You are rebreathing in and out, so it does not work.
So what is it? See, deadline between the carbon dioxide narcosis and therapeutic carbon dioxide, which you are talking.
So therapeutic one has been used a lot actually in animal models to reverse the ischemia, that you can use a little bit of higher carbon dioxide. And there was a very, very recent clinical trial of it was just published, I think, in May or June in New England Journal of Medicine for patients with post-cardiac arrest. When they were managed with keeping the carbon dioxide on a higher level as compared to the carbon dioxide at the normal levels, it did not show any difference in terms of outcomes because the damage was too much and they did not evaluate all the things what was happening. So that was a little bit of complex situation. But there is no point actually in increasing carbon dioxide because the problem is, I give examples of, say, when we were taught photosynthesis, we were taught a limiting factor. So once you keep one limiting factor sustained and you cross that limit, another factor becomes a limiting factor. This no longer is the limiting factor. So problem is if you keep carbon dioxide on the higher level for a sustained period of time, other conditions start settling it. And this is where you start going into carbon dioxide necrosis. Instead of increasing the blood flow, it knocks you down. It suppresses your respiratory center. It suppresses your breathing capability. So that's the problem. Initially, it stimulates, then it suppresses. So it's a double-edged sword. We need to live on a small range only.
Yeah, in fact, some of the patients over enthusiastically, when they have obstructive sleep apnea, they give oxygen. And that oxygen makes them go for carbon dioxide narcosis.
Exactly.
Sir, there is a question. Improvement in slurred speech takes how many months in a patient with mild MCI stroke?
So the classical teaching for stroke has been that every stroke will improve. If he does not die, every stroke will improve. The biggest question, the challenging question to stroke neurologists is how fast it will improve and how much will it improve. A lot of theories have been given and it boils down ultimately to the neuroplasticity, how much your brain cells are ready to improve. The brain cells which are lost, they have been lost forever. They are not going to be replaced. The question is the surrounding, the neighborhoods, the other side, how much are they willing to learn the function of lost cells? So it totally depends on that. There is no time frame. There's slurred speech. Slurred speech may improve in 3 days' time, totally back to normal, and it may never improve. So answer is, if So what we say is in patients who are typical stroke age of say 65 years or more, if the slurred speech persists for anything more than 6 months, probably it's not going to go away. In younger patients, we say, you still have a hope. It can improve. It may improve with some kind of speech therapy involvements, other interventions. But as such, there is no rule that it will improve in this much of months. In older people, you can say safely, if 6 months it will not improve, it is unlikely to improve. We don't say it will not improve. It's unlikely to improve. But you should make all efforts early in the phase of the stroke, because the maximum recovery occurs immediately after a stroke within first few weeks or first few months. That's a time for aggressive rehabilitation programs.
Yeah, I'll just add up to what Dr. Vijay had said, and there's no time limit for recovery following a stroke. And there are multiple factors that come into play, and the spontaneous recovery, stops at 6 months, and but functional recovery occurs because of all the neural plasticity, and if it is just pure dysarthria, it has a good prognosis in terms of recovery, and that we intervene, that is the best way to improve outcome, better outcome, and most of the dysarthrias improve, but maybe sometimes some of the words and all, they may have difficulty. That is what we have seen, but most of them return back to normal.
Yeah, Jairaj Pandian, myself and yourself were more interested in starting more stroke units. So you can give a drive-home message to everyone about starting the stroke unit, because for the last 5 years we had been, requesting all the physicians to train themselves for stroke unit. So you can add one sentence, and so people who are watching, they'll be benefited.
Yeah. So this is a World Stroke Day, and from Indian Stroke Association perspective, and also from World Stroke Organization, we stress on improving stroke care services. And from WSO, we have this massive effort called Implementation Task Force, trying to work with the country champions, with the government and WHO, to promote stroke care services. And we know in India we are close to about 3,000 neurologists, and about 50% of them are in South India. And North India, the proportion is less. And so in a situation like this, we can't depend on a neurologist to run a stroke program. So that is where we have this physician-led stroke units, and we have been promoting. And currently there are 7 states where this particular model has been implemented in government district hospitals, with the hub and spoke model. And with Dr. Muruganathan and the API, over the years we have been working on this, empowering physicians to start with stroke units. It's not a big thing, and basically you need to identify a dedicated area in the hospital, and with dedicated beds, you need to have trained staff nurses. Most of the things can be done by the staff nurses. And in terms of providing thrombolysis, you need to work with the emergency department, the radiology department, and you can easily start a program. And there are several stroke champions available in every state, and we can handle most of you. And in the beginning, that is what we have been doing with many of the physicians who are interested, and we are very keen to help.
Hello, sir.
Yeah, there is one more question, Dr. Vikram.
Yes, sir. 1 second.
Can I go ahead and ask Dr. Sharma one more question?
Yeah, sure.
Yeah, Dr. Sharma, this is regarding hypertension and post-infarct dementia, because we do not talk about the late complications of the stroke, and we always talk about the acute complications of the stroke. So it has been seen and studied that the blood pressure, if you reduce further below say 110 down, and the systolic and the diastolic below 60s, then the post-infarct dementia occurs much more. The population, almost 2 out of 1 will be dementing in latter part of life when they are more than 65 years of age. So other than controlling the blood pressure, which the ESC guideline in 2023 June said the blood pressure should not be reduced less than 120/70, because you will land in post-infarct dementia later. So what is your advice? How do we protect our brain in long term, not an acute stroke, against dementia?
Actually, Vijay, before Vijay answers, I would like to add one point. Whenever somebody has got hypertension in the middle age, if you don't control the middle age hypertension, those are the people, instead of developing paralysis, they will have dementia. So most of us would not understand, do not think about dementia because they only think about paralysis. If you don't control middle age hypertension, they will land in dementia. Forget about post paralytic dementia. Even otherwise, they will develop dementia. Am I correct,
Yes.
Sharma?
Yeah. To some extent, this is correct. Dementia is a more complicated subject. It's not only the stroke component. There are a lot of other things which happen, and a lot of things they are dependent on hypertension. So hypertension, which is sustained, leads to white matter disease. Previously, we used to believe that this is some form of small vessel disease, but that leukoencephalopathy is a predominant component. We have subcortical small lacunes. Now we know that there are cerebral microinfarcts also. There's a newly identified, this cortical microinfarcts, newly identified thing, because only a 3 Tesla MRI can see it much better. Plus the sustained hypertension leads to amyloid angiopathy also. A lot of things they contribute, and all of them almost are related to sustained hypertension. And what is believed, what you are saying, this is a new concept, that after a stroke, if you keep the blood pressure too tightly controlled, then they may go into dementia. So one explanation for that has been that you kept the brain working at a very higher level of blood pressure, and you moved your total cerebral autoregulation curve, which I showed you, on a higher level. And now, after sustaining a damage to the brain, not only the stroke which you suffered from, but also all other things which, like I told you, the leukoencephalopathy, I told you small vessel disease, I told you subcortical lacunes, cortical microinfarcts, amyloid angiopathy, all of them. Now suddenly you start going into a very controlled blood pressure, that means less than 110. So you are affecting your brain in a reverse manner now. First you kept it at a higher level, now you are not providing enough blood. So that may accelerate the process of dementia. So it's just an acceleration, it's not the cause probably, it's the accelerating all the damages which you have sustained over years, and this is a cumulative effect of that. This is why people develop dementia. So it's not that particular stroke which led to dementia. There are a lot of, probably thousands of those cortical microinfarcts and lacunes which are also adding up to this big stroke and causing dementia. Dementia is more complicated issue than stroke.
Sir,
And
Vijay
we have
sir,
started understanding about it now.
Vijay sir, in India, now everyone knows that mechanical thrombectomy has become a standard of care, and the window for mechanical thrombectomy has been extended up to 24 hours time. But what is expected by the numbers of stroke in India? Around 3 lakhs mechanical thrombectomy has to be done every year. We are doing around 3,000. Even after many years of standard of care, the number needed to treat for mechanical thrombectomy is 2.3.
Yeah.
Why we are not talking more about it? And what about in Singapore? What is the numbers and how many you are doing now?
So Vikram, what I can tell you is that because of the small size, because of more awareness, because of probably higher level of education and awareness, plus the close proximity, our response time of the paramedical ambulance services. Like in Singapore, the paramedical response time is 8 minutes. So within 8 minutes, the ambulance will reach your house, wherever you are. So all these things, they have led to that we are able to achieve somewhere around 25 to 30% of thrombolysis for acute stroke. And we do, on an average, nearly we are reaching about 30% of our strokes, they go for mechanical thrombectomy. So every eligible patient gets it. So there is no denial for it. But we know it that in a small place like Singapore, where everything can be arranged, we still have a long way to go. So the things are improving, but definitely India, the problem is, what Jairaj was telling, this is exactly correct. That 3,000 neurologists for such a big country is never enough, and 50% of them are in South India. So you think of the population which is living in most of the North India, and even these 3,000, I know that these are limited to probably like 30 or 40 cities maximum. Once you cross, the 25 kilometers away from a major city, there is no neurologist available at all. So you still have to go a long distance, to reach that number.
So that's why, as Jairaj sir told, it is important to make physicians aware of it and make stroke units so that they can recognize large vessel occlusion and shift, because 24 hours window is huge.
Yeah.
So Jairaj sir, what?
Vikram, more than anything, Vikram, everyone should know stroke mostly is due to hypertension. If they can control hypertension, they don't need to go for all these problems. So earlier itself, if they can control, we can prevent many strokes.
Correct, sir. So that we are trying since decades. Jairaj sir, how to improve the mechanical thrombectomy numbers?
Yeah. So there are several ways we can do. One is the awareness. That is important. That is why there's World Stroke Day and many things that we drive the awareness program. But for India, what I would say is patients. We can't completely depend on ambulance. We can't have the developed country model of having pre-hospital ambulance service. Maybe tier 2 or tier 3 smaller places it may work. Even the hub and spoke may work in tier 2 and 3 cities.
Hello, sir, we lost you, sir.
Yeah, we lost Jairaj.
We are not lost Jairaj, we lost the connection.
You want to make us hyperventilate, sir.
And Dr. Vikram, there is a question in the chat box.
Vikram, you said about laughing therapy. I think, is it useful? We'll make a lot of laughing clubs also across the country.
They're already there. I know they're already there.
But they are not very aggressive, only very few people go and laugh. But we should have in every small town, small village, this should be promoted.
Correct, sir. But everything in medicine, we need to have RCT.
Yes.
Some people should cry and some people should laugh, and we have to see the outcome. Otherwise, I have many hypotheses. I can't, if I speak well, I can't put it those things. Though these things are hypotheses. We need to prove it. Then only we can publish it.
But anyway, by laughing, you are improving increasing the hyperventilation in one way is also, it's evidence only.
Correct, sir.
Now
we are discussing about the strongest evidence in medicine, sir.
That's true. I totally
Mechanical
agree.
thrombectomy.
Yeah.
Okay.
There's nothing
It is better than the defibrillation for VF. Correct. It is one of the best evidence, and we have that. And the window is 24 hours. I know that I'm doing this since 2007, and now things are improving. Means now people are thrombolizing in Davangere, Raichur, Mysore, Shumaga, and they are identifying large vessel and shifting here. So why we can't promote this more and more? So this is one of the strongest evidence in medicine.
That's true. That's true. There's no doubt at all about it. It's just you need a support staff and that they identify, and the patient reaches you in time. So that's the biggest challenge at present.
Correct. So Jairaj sir is back.
Dr. Vikram, can I ask a question, please?
Yes, sir.
Yeah, so, we've been talking about hypertension not being controlled. We're talking about strokes. Something that's dear to my heart and yours also recently, I know, is before these happen, before hypertension becomes uncontrolled, before the risk of heart attacks and strokes increases, we have a lot of obstructive sleep apnea, affecting at least 10% of our adult male population. That's one group we should really be focusing on, looking at these things, because they are about a third of patients with sleep apnea, with stroke have sleep apnea. So you have that, very rich ground to look at the necessity of evaluating them and, of course, of instituting your preventive protocols.
Correct, sir.
So everything goes back to a healthy lifestyle right from the young age. You need to go back, from probably teenagers, it has to start. Like Singapore, I can tell you, we used to have in schools something called Tough Club. So every student will be weighed, they will take the BMI, and all those in the higher percentile of BMI, they will be made to run on the ground 3 times. So this was called a Tough Club. And then parents, they started just saying that you are discriminating, and the ministry had to stop it. But there's a strong motive actually starting from that age that don't allow overweight and obesity to develop, because one of the major components of OSA is the overweight. Other factors are there definitely, but this is one of the major components. So everything boils down to a healthy lifestyle. It will prevent not only the brain strokes, but even before that, all the heart attacks will be stopped.
Correct, sir. But what we are seeing nowadays is even people who are fit, they have severe OSA. So
True.
the cause or effect, obesity, I feel it starts with OSA and then weight gain happens.
It's a vicious cycle.
Yeah.
Absolutely.
It's a vicious cycle. It's a vicious
But I would
cycle.
agree with Dr. Vikram. Very often it is the OSA, which is the first thing which sets off this cycle.
Yeah.
And so we need to focus on, the primary problem and, of course, take care of the other problems that go along with the OSA.
It's true. Definitely.
You are unfinished. Yeah. Can you continue, sir?
Yeah, this is about the thrombectomy. So the major hurdle is the cost, and so in the last meeting we stressed that most of the thrombectomies are done in private sector, and people are not getting empaneled because of the low cost and the reimbursement issues. So we have revised it to a very reasonable level, which can be very good for the private sector hospitals. So that is one thing where if in private hospital, if we are able to do it free of cost, then there'll be more numbers, and that is the second hurdle we could tackle. And the first is the awareness, coming to the right hospital on time, and at least in South India, some sort of hub and spoke exists, or a very informal referrals happen. But in North, what I have seen is, despite all the awareness, talking to our own professionals, sending a patient at the right time for the procedure, it doesn't happen at all. We are the only medical college in Northwest India which has a comprehensive stroke program, but still, the referrals from people who they know that we are the only center that can do thrombectomy, it is very, very minimal. It just patients come on time because they know something is here, and so these are some of the major hurdles, I would say. Cost was one important thing, and then third is the capacity building, which we need to do it in ward footing. We should have stroke fellowships, and the ISA has started the initiative through National Board of Examination. Maybe 5 years from now, we will have more centers training neurologists to do intervention.
Another thing, Jairaj, what you can do. Jairaj, are you there? Or?
Yeah, I'm there. Yeah, I'm there.
Okay, you write to all the state governments, like Tamil Nadu government reimburses the private sector stroke program also. So I think if you write to all the state governments to support the private practitioner and private neurologist also to do that, and then the patient get reimbursed, that way you can improve the stroke care.
Yeah.
Yeah, sir, one more thing, I request all the physicians or API and CSI. So stroke is a pain-based disorder. So that's why for World Stroke Day, it is important for everyone to create noise about the symptoms of stroke, that it is a preventable condition or treatable condition. Even now in Bangalore, I know many people go for alternative treatment, for example, Maddur, Palamner, even within during critical phase. So unless all doctors come together and make noise, it is not going to penetrate to the society.
Yeah, I agree with you. It's a teamwork. That's why we have to create awareness among the physicians, practitioners, and the public and the government.
Yeah, Dr. Vikram, I think before we close, we'll have a take-home message from all the faculties.
Vijay, sir?
No, everything is prevention. Prevention is the cure. You need to start at a very early age. We want to prevent any ischemic episodes in the body, whether heart attack or stroke, and especially in a population with the genetically predisposed for ischemic events. We need to be more careful.
Jairaj, sir?
Yeah, I would have a different approach, an integrated approach, I usually say, that is prevention and developing services, stroke care services together. That is how we can tackle the burden of stroke in our country and also in countries where we have a very high burden of stroke care.
Yeah, I think I agree with both. I think prevention is also important in treatment. In prevention, what is required is we can't prevent MI and stroke. We can only postpone it by a few years because humans, we have to die. Correct? So we can prevent MI and stroke by 50, 60 years. Otherwise, if we prevent stroke and MI, patients will die of cancer. So I think we can prevent young strokes and young MI and postpone it to the elderly after 80 or 90, I think. So we can't stop stroke or MI. So I think that is my take-home message.
But everybody will agree, healthy lifestyle and health education for all is one of the key for prevention.
Correct, sir.
Yeah, Dr. Murali Mohan, sir, your take-home message.
I think it's all been said, but what I would like to emphasize is we are talking more and more about going earlier in the course of disease. So we've already been talking about pre-diabetes, we're talking about pre-hypertension, we started talking about pre-COPD in respiratory medicine. So I think we need to talk about pre-stroke and identify this group, prevent, and of course, inevitably stroke is going to happen. Let's reduce the mortality, let's reduce the morbidity, and the rehabilitation services should also be improved apart from the acute care.
Yeah. Sangram, one message, Sangram. Artificial intelligence has come in a long way, and that's going to do real magic, because by looking at the eye scan, you can say who will develop stroke, who will develop myocardial infarction, and things like that. So artificial intelligence will be a real game changer in the years to come.
Yeah.
The Mala,
Sure,
sir.
sure.
Yeah, fine. Thank you, Vikram. Thank you, Dr. Sharma. And it was nice talking to you guys, being a cardiologist. But still, I'll say that prevention is better than cure. But however, all diseases cannot be prevented. So we should diagnose it early and we should treat it early. That is what I have said. The mnemonic, use it, be fast. B is the balance. When you are losing your balance for anything. And E is the eye changes. F is the facial changes. A is the arm changes. And S is the speech changes. So this has to be taken to the grassroots level where the people can recognize, be fast. And they can reach a center where they just stroke protocol and enhancements of stroke protocol earlier so the patient can get treatment. Two, and we didn't touch upon or something which is a new treatment which has come up in 23, stem cell therapy. Maybe looking at prevention, looking at treatment and looking at early treatment, still there is a place for stem cell therapy, which we can try or experiment and get the benefit out of this. So thank you very much. All the participants, it's nice to talk to you guys. Thank you very much.
Yeah, so I request Dr. Vishwanath, Secretary, to propose a vote of thanks.
Yeah. Good evening, sir. It's indeed my pleasure. First of all, I thank our distinguished speaker, Dr. Vijay Kumar Sharma sir. We are fortunate to have you. I think this is the second or third time through Dr. Sangram Biradar sir. Thank you very much. It was a very comprehensive lecture covering, as you said, brain is doing a lot of things we don't know. I think that really you summarized it in a very nice manner. I also thank Dr. Mahala sir and Dr. Jairaj Pandian. Of course, special thanks to Dr. Vikram. I think morning we had a fruitful interaction with Dr. Vikram Uded in God program. She showed about all this about mechanical thrombectomy. I think somehow it was a coincidence that we taught so many postgraduates today on the World Stroke Day regarding this neuro intervention. Yeah, I again thank my API chairman, Dr. Murli Mohan sir, a constant guidance advice. And the special thanks to Dr. Biradar sir. As Murli Mohan sir rightly says, he is our engine of academic activities for API. Thank you once again, bringing all the stalwarts to this program. Thank all the participants and API members. Thank you. Thank you, sir.
Thank you, sir. Thank you, one and all. Dr. Sharma, Dr. Vijay Kumar.
Thank you.
Thank you, one and all.
Thank you, Sangram.
Thank you, sir. Thank you, sir. Thank you.
Good night, everybody.
Good night.
Good night.